The surgery doesn't work by itself. I think that's the very first message is it's not one size fits all. How successful a patient is has much more to do with the effort the patient puts in as opposed to which procedure.
For the person listening who is overwhelmed or just outright confused, today we're breaking it all down with my very own surgeon, Dr. Christopher Hart.
Besides deprivation, that's not a long-term strategy.
Welcome back to Bariatric Paths, where we have real conversations about weight loss, the bariatric journey, and the mindset shifts that come with it. If you're new here, I'm Jatoya, and this space is for people navigating any weight loss journey in real life. Let's get into today's episode. If you think weight loss surgery is a one-size-fits-all, well, you definitely need to think again. We have the sleeve, the bypass, SADI, Duodenal switch. Each one has a different level of restriction, risk, and impact on your body. And today we're breaking it all down with my very own surgeon, Dr. Christopher Hart, an award-winning, board-certified general and bariatric surgeon with over 25 years of experience helping patients improve their health and achieve lasting weight loss. And he is pretty good, if I may say so myself. He's going to be walking us through all of the things that we need to think about when choosing the right surgery for our journey, what the prep process looks like, and answering questions that every patient should think about before they commit. So thank you so much, Dr. Hart. Welcome.
It's my pleasure. Thanks for having me.
So we're going to go ahead and jump in. I want to first start with breaking down the bariatric surgery types. So for the person listening who is overwhelmed or just outright confused by the different surgeries, what is something that you would want them to hear first from you as your surgeon?
So I think the first thing is that there's a lot of options. And I'm one of those people who doesn't think there's one size fits all, right? We can figure out what's right for an individual patient. And that's why we don't just offer one option. And there's a whole spectrum. So there's medicines, there's surgeries, and within the surgeries, there's a spectrum. There's lap bends and gastric balloons, these things that are kind of, gone by the wayside for the most part, all the way across to, sleeve gastrectomies and gastric bypasses. And then I call them the acronym abbreviation surgeries, the duodenal switch or variations on the SADI, the BPD, lots of different versions of that. And so you really have to just sit down, patient with the surgeon, try and figure out what's the right option for that person. Because it's not, people always ask me, well, if it was your family member, which would you recommend? I said, well, which family member? I mean, it would be different. I think that's the very first message is it's not one size fits all.
So what is the difference between, let's just do the four main ones. So the sleeve, the bypass, the SADI, and the switch.
Well, I can make it even simpler. I really kind of combine the SADI and the duodenal switch really and BPD all together in one. So if I think about sleeve, really what we're doing is just taking the stomach from the size of, roughly a balloon, every stomach's a little bit different size, down to the size of a banana, more or less. So we're just making the stomach smaller, but we're not rerouting anything. Everything still goes the same way. There are some hormonal changes. There's some things with all of these surgeries where what we really want to do is we want to decrease some hunger hormones and we want to increase satiety, meaning you eat and you feel like, oh, okay, I've had enough. So we want to increase those signals. We want to decrease the hunger signals. So the sleeve does that, but it mostly does that by restricting how much you can eat and making you so you're satisfied with a smaller amount. But everything still goes the same way. There's really no malabsorption there. Everything's still going to get absorbed more or less the same way. Other end of the spectrum is the duodenal switch, and I'm going to put SADI in with that. There's a lot of variations on that theme. But basically what we're doing, with or without reshaping the stomach, what you're mostly doing is hooking the beginning of the small intestine near the end of the small intestine. So things kind of shoot through.
Okay.
So it's really the most malabsorptive group of surgeries that we have. So if you can imagine, if you hook the beginning to the end, things shoot through, don't get absorbed as much. So very effective for weight loss. If you just look at strictly at the numbers, it's one of the most effective as far as weight loss. But it also comes with a lot of potential side effects, as you can imagine. So it's harder when you're decreasing that much absorptive capacity of your intestine, a lot more trouble keeping up on nutrition, certain vitamins and minerals, all the micronutrients you need. It's really, really, really important to stay on top of that. So there's more side effects with those. There are a lot of surgeons that love that operation. I really tend to be very selective and somebody that I would recommend that for, because I think we can get close to that amount of weight loss without risking, as much of the malabsorption and other side effects. And then kind of in between those two is where I put the gastric bypass, which is really has always been the gold standard, at least since I've been doing this. And it's really been out, in more or less its current form, for a few decades. I started doing this in the 90s. I'm not going to date myself too much. So, and then, late 90s, early 2000s, we've, instead of cutting people wide open, we started doing the little bitty incisions.
Mm-hmm.
But the thing about the bypass, the gastric bypass, or you'll hear that term Roux-en-Y gastric bypass. It kind of combines a little bit of both. So it reduces the size of the stomach, kind of in a way the sleeve does. And it does bypass part of the small intestine in the way the switch and the SADI do, but not nearly as much. It's just small. It's a smaller amount, about 150 centimeters. Some surgeons, even as little as, let's say 75, 100, 150 centimeters of small intestine. You've got a lot more downstream, so you still can absorb. It's not very malabsorptive. There are a few nutrients that we have to really keep an eye on supplementing when you do gastric bypass. So it's not nearly as much as it is with a duodenal switch or a SADI. So a lot of different options. The first thing that I hear from patients is, well, I want the one with the quickest recovery or the least invasive. And the reality is, for most surgeons,
they're all the same.
We can do these all through little tiny incisions,
yeah.
either laparoscopic or robotic. And the amount of time that downtime is really very similar for these. So, your time to be up and around and going, very quick. The amount of time as far as the full recovery and things very similar between them. So that's probably the first thing I steer people away from, is like, well, I want the one that I can recover from the fastest. It's really that's almost take that out of the equation. They're really all very similar in that respect.
So because I've heard that some people feel that the SADI is less invasive than the bypass. Is it about the same? It's just a different rerouting, but both of them are kind of doing the same thing, it sounds like?
Yeah. So I think that depends on what you mean by least invasive or less invasive, because again, when we're just talking about, well, what's the size of the incisions, they're all little tiny things, and your recovery is the same. So invasive in that standpoint, they're really very similar. But in the sense of what are we doing internally, as far as rerouting your intestines, the SADI and the duodenal switch are really the most invasive of the bunch, because they're where we're bypassing the majority of your small intestine.
That's
so
interesting.
It's the most malabsorptive procedure. Yeah.
I've heard some people say that they thought SADI was like the baby bypass, and I was like,
yeah, no, I would flip that around, because physiologically and anatomically, it's the most drastic. But having said that, if you look at can I get away with eating more, depending on the version of duodenal switch, and there's a lot of different. There's BPD, DS, SADI. There's a lot of different versions. You may or may not, depending on the version, you might be able to get away with eating more, or eating stuff you shouldn't eat, as compared to a bypass. Keeps you a little bit more accountable. When people start telling me that, oh, well, I want to be able to eat whatever I want, I'm like, well, okay, well, let's stop back and not even talk about which procedure. Let's talk about whether you should have a procedure.
Yeah.
Right? That's a whole other conversation.
What about the actual deciding based on how much weight you want to lose? Like, is there a threshold you should think about when deciding which surgery you want?
Well, there is. And I will tell you, there's not hard and fast rules on that. You can ask, a handful of my colleagues and get a handful of different answers. We have some general consensus. Really what we're more focused on is, what patients would benefit from surgery as opposed to which surgery in general. One of the things that, my entire, basically 3 decades of doing this is trying to find a test, like which can we give a test to a patient beforehand to figure out which procedure is going to be best for them, right? And we don't have just one test that goes, yes, you're definitely going to do better at this, or definitely you're going to do better at that. I have a lot of things that I think about when I try and recommend what's right for one patient versus another. And a lot of that has to do with just sitting down with the patient, figuring out what the patient's goals are, like you said, right? So how much weight do you want to lose? That's almost another whole topic. But what kind of surgeries have they had before? What are their medical problems, right? A lot of things I might adjust what procedure I would recommend to somebody based on their medical history and their goals and their lifestyle and what they do, as opposed to, just how much weight do you want to lose? Right? I think that's probably would be pretty low on my list. The other thing I always emphasize is, if you look at like how much weight you lose and what's the average weight loss for each of these procedures, they overlap.
Mm.
They're not exactly the same,
Yeah.
right? There's a little less weight loss for a sleeve relative to a bypass, relative to a duodenal switch, right? But all those curves overlap. And one of the things that I tell patients on their first visit with me beforehand, and I say first visit because you really should be seeing your surgeon, more than once. Don't just go get the surgery.
I saw you a lot.
Yeah, well, there you go. Right. We got to get you ready, right? Because one of the reasons we say we get you ready is because this is the point I'm trying to make is I tell people it's not quite as much, although there are medical reasons why I would recommend one versus other. But as far as how successful a patient is, has much more to do with the effort the patient puts in as opposed to which procedure, right? So I could have, a patient that, statistically, let's say that the gastric bypass loses a little more weight than a sleeve. But if I have a gastric bypass patient who on paper statistically should lose more than a patient with a sleeve, but the patient with a sleeve is doing all the work and the patient with the bypass is like, what? You told me to do what? Right? They're not going to lose as much weight. They're not going to be successful. Right? So it's really a lot of effort that the patients put in. I tell everybody the surgery doesn't work by itself, right? You still have to eat right. You still have to exercise, right? Now notice I said eat right, not diet. Right? Yeah, it's a tool, right? So I think it kind of like if you think of an arch, right? Yep. What holds up an arch? It's that keystone in the middle, at the top of the arch. It holds it together. So I think a surgery is that keystone of an arch, right? It holds it together, but you still have to have the good nutrition. You still have to have the exercise. Now, again, like I said, good nutrition is not diet. Diet's deprivation. That's not a long-term strategy, right? At some point, you're going, can't wait to get off this diet. So what we need to do is make it so you can eat a small portion of something healthy and be satisfied with it, right? And you learn, as you've experienced, you learn to trust it, right?
Yeah.
I can eat a small amount of something healthy. I'm not going to be starving again in an hour.
Exactly.
Go on with your day.
Moments like this is why this podcast exists. So many people on a weight loss journey carry this quietly. If you want more conversation like this, subscribe and stay connected. Remember, your journey is yours. You are not alone. Let's jump back in. So that process from after that first consult to surgery, what can someone expect for that prep process to look like?
Yeah. So the first visit, if you remember way back, right? So you're going to sit down and you're going to talk with me. You're going to sit down and talk with one of our registered dietitians, so I'm going to go through all your medical history and figure out, where we are, what your goals are, what I think I can provide if surgery is the right thing, or if medicine's the right thing. Maybe we go that route. We've got those options now, whatever it is, and we figure that out. And then we have to talk with one of our dietitians who are just fantastic. They're a great resource. And sometimes people have actually been working with a dietitian before, and that's fantastic. Or our dietitians are, specialized in bariatric. Like there's some dietitians that work with kidney patients, dialysis patients, or diabetic patients, or there's different versions, just like surgeons, right? You don't want me to fix your broken arm. I would be horrible at that. Right?
Yeah.
So it's the same thing with the dietitian. So we have very specialized dietitians that are used to our patients and what our patients' situations typically are. And we'll work that out. And then we send you off for some testing. Maybe you've already had testing. It's not unusual. I might not be the first, bariatric surgeon you've seen, and you go and saw something like, okay, now I heard about this guy, and you come see me. Whatever it is, figure out. There's a set of testing that I typically would like to see not just where you are as far as medically and what your health conditions are, but also what I think the right operation might be, and also we want to try and make sure we can get you through the surgery safely, right? Every now and then I find somebody like, oh, did you know you had a heart problem? Let's get you off to the cardiologist first, right? You don't want to find that out on the OR table.
Yeah. You told me about my hernia. I didn't know I had one.
Yeah. Right. There you go. Right. So all these things that we want to evaluate before. Again, that's why I don't see you on Tuesday and operate on Wednesday. It's just not going to happen. Right. So, right. I tell everybody, well, this is not drive-by surgery. It's going to be a process.
Yeah.
So there's a lot of medical evaluation. Then there's also the education process where, again, like I mentioned before, we're going to get you coached up to be as successful as possible. What's it going to take on your part? When we talk about that good nutrition and we talk about that exercise, what does that really mean, right? What are the specifics on that? So we kind of go through, where the patients are and what we need to do. And it's different. Again, it's different for everybody, because just think about, we talked about like where people start from an exercise standpoint, that's different. But think about it from a nutritional standpoint, right? So I have patients who are vegetarian or vegan or pescatarian or ovo-pescatarian, or they've got celiac or whatever it is. We have to figure that out. And when I say we, I'm mostly talking about our fantastic registered dietitians that do a lot of that work to figure out.
And they're really good.
What are we going to have you so we can make sure you're still getting really good nutrition afterwards, right?
Yeah.
Because it's really important. I have people come in a lot and they go, oh my gosh, I don't want to be malnourished afterwards. I'm like, well, I don't want you to be either.
Yeah.
Right. And so we stay ahead of it. Right.
Mm-hmm.
We get baseline levels, and we follow those levels afterwards. We may have to adjust them. Right. Sometimes the ones I really love is when we're following your blood work after surgery as you're losing weight, and we see other things happening. Let's just take as example your cholesterol, and your cholesterol is coming down. And that's like, well, you know what? Now I think you need to go have a conversation with your cardiologist or your primary care about, do you still need this cholesterol medicine? Right.
Mm-hmm.
So just as an example, there's a lot of different things as we move on after the surgery. But to your point, before surgery, so there's this evaluation process where we're testing people. It's blood work, it's, EKG on your heart, basic things, right? I like to do a barium swallow. Different surgeons like to do different ways of evaluating the GI tract. And then there's always the part about scheduling, right? It was easy 20 years ago, 25 years ago, maybe. You came to see me, and I would just, at the first visit, I'd say, oh, let's pencil you in for date 2 months from now, because I knew I could get the testing done and get you coached up and educated on what we need to do to be successful, and then get the insurance approval, and then get you on my schedule. Right?
Mm-hmm.
And we could get that done. Well, now we can still do all those things, but that insurance piece, if you're using insurance, and there's patients that just don't have that coverage, and it's a whole different way that we help people with that. But if you're going through insurance, sometimes it's very simple. Send it off for approval, and 48 hours later, voila, here's your approval. Let's go schedule. But other times it's like, oh, you've got to meet with the dietitian for 6 visits or 3 months or 12 visits or 6 months or whatever arbitrary reason they come up with, right? Well, that stretches that out. Mm-hmm. And I just, so when people ask me at the first visit, like, when are we going to do this surgery? I say, look, I don't know. I don't know what your insurance is. I don't want to know what your insurance is. I mean, I purposely, I made a promise to myself when I was fresh out of residency. It's like, and I heard some old timers talking about what they were going to do. And it wasn't even in my specialty. And I'm not trying to throw anybody on the bus, but, well, this person has good insurance, I'm going to do this. And this person doesn't, I'm going to do that. Like,
yeah,
that just didn't seem right to me.
Yeah.
Right? So I don't want to know. I'm going to figure out clinically what I think is the best thing. And then we'll try and get the approval for that. And every now and then, unfortunately, the insurance is going to go, no, you don't have coverage for that. And then we got to figure it out, right? Mm-hmm. That's a different conversation. So all of those things have to happen, right? We start off with some education, figure out where you are, then a lot more education and evaluation to make sure we're doing the right operation, getting you safely through the surgery, insurance approval, more education with our dietitians, getting you on the schedule. It really varies how long that process is.
Yeah, mine was 10 months. My insurance was very strict.
Yeah, I would tell you that, thank goodness, unfortunately for you, but thank goodness that's not usual.
Yeah.
Right? It's typically not. That's a pretty extreme example that it would take that long. But it unfortunately
they
does happen.
Most of it though, so it was okay. I let them out. It was fine.
Now, I know people that they come in and they have been thinking about it, or maybe their doctor has been telling them, like we said at the beginning, you got to lose weight. You got to lose weight. And they finally get to the point where they're like, you know what? I'm ready. Mm-hmm. I'm ready to do this. And as soon as they do that, they're like, I'm going to go. Let's go tomorrow.
Now.
Next week. Let's go.
Yeah.
Right? Let's go. Wait, remember, we got to do all these things to make this as successful and safe as possible. So let's work through that process. So it's unfortunate that sometimes you're ready and the insurance hits the brakes on you, but it does happen.
Do you think that's the part that patients either underestimate or try to rush through the most, is that time period? Or what part do you think they're not really understanding when they're getting ready for surgery?
Yeah. When I first see a patient, I get that they're excited. They want to get this done now because they finally got themselves to a spot where they're committed to being healthier, right? And I want to go just as fast as they do, but getting all our ducks in a row, right? Well, let's do this the right way, and then we'll be as efficient as we can to get there. And sometimes that's pretty fast, really. And we've got just a fantastic staff here that, as you know, that work to our coordinator is just amazing and how she stays on top of everything and gets people to that process. So that's always important. It's the people who say, well, I have X event in 3 months or whatever, and I want to look good for it. Like, ooh, okay, we're not doing this for the right reasons.
Yeah.
Right. I mean, I get it, but no, right. That's not, this isn't a quick thing. Those are the people who are going to get, like, because then I ask them, I'm like, okay, well then let's just say we could get everything done. You're still not going to lose the weight that fast, right? That process, most people tend to, it depends on where you start. Most people, I think that the earliest is typically around 6 months. That's pretty unusual. It's typically maybe 12 to 18 months that people kind of get in the range of whatever their plateau is going to be.
Mm-hmm.
And sometimes it's even longer than that, depending on, again, where you started. But if the people that just have one goal in mind, oh, I've got a wedding, I've got a this or whatever it is, and I want to look good for it. Like, okay, well, what are you going to do after that? Then what's the motivation?
Mm-hmm.
The motivation needs to be your health, getting you where you can enjoy your life. It's not, I want to look good for this one event, because then what are you going to do after that? I always worry about those people. Like, well, are they going to exercise after that? Are they going to make the right food choices? Are they going to think about what they're eating?
Because those don't allow
maybe
for
not.
lifestyle changes, because they're so arbitrary. So you're just kind of like a quick fix almost.
Absolutely. It's a lifestyle. Now, does some event like that get them to thinking about it? Yes, that's fine if that's the motivation to get us started, but it's got to be more than just that.
This episode may end here, but the journey doesn't. Parallel Paths is the Bariatric Paths membership for people who want continued support, real conversations, and connection beyond the podcast. If that sounds like what you need right now, go to www.bariatricpaths.com and see if the community feels like the next right step for you. Remember, your journey is yours, but you are not alone. Go out there and crush it. Bye. This podcast is for support and inspiration only. It is not medical advice. Always talk to your doctor or care team about what's right for you.